Good morning. I'm delighted to welcome you as co-lead with my colleague, Professor Francis Hogan, to the iPASTAR launch of our website, the launch of our project, and our symposium today. Just before we start, I'd like to just go over a number of etiquette issues for the symposium today. I'd like everyone, if they could, mute your microphone and camera when joining the meeting. Please ensure that you sign up with your full name. This is required if you wish to avail of any CPD credits, which we can award for this webinar session. You can also use the chat function if you wish to ask questions during the session, and everyone will be able to see your questions. And we also have the option to submit questions after the symposium through our email. Please be aware that this webinar will be recorded and shared following this meeting, and we invite you to join the conversation on Twitter using our hashtag. Now I'd like you to sit back and enjoy our symposium this morning. Next slide. So this is an overview of our program this morning. My colleague and co-lead, Professor Francis Hogan, will give an overview of iPASTAR. And then I'm delighted to invite our keynote speaker, Professor Bo Norving, Professor of Neurology at the Lund University, who will discuss the action plan for stroke in Europe. We will then follow this with a panel discussion, and session 2 will give an overview of the iPASTAR PhD projects, where our iPASTAR scholars will present the work that they plan to do over the next 4 years. We're then delighted to invite our patient partner on this project, Mary Scullion, who will give her experience of public and patient involvement in iPASTAR. We will then conclude with a panel discussion and closing remarks. So I hope you enjoy this morning's symposium. I'd like to introduce my co-lead on the iPASTAR program, Professor Francis Hogan, who will give an overview of iPASTAR. Thank you, Francis.
Good morning, everybody, and thank you very much, David. So, iPASTAR, Improving Pathways for Acute Stroke Care and Rehabilitation, is a collaborative doctoral award, or a CDA, that is funded by the Health Research Board of Ireland. It is a joint collaborative doctoral award hosted by the Royal College of Surgeons in Ireland, University of Medicine and Health Sciences, and University College Dublin. And it is in conjunction with a very large consortium of national and international academics and partners in policy and service. So if we move on to the next slide, Patricia. Our iPASTAR program is focusing on stroke, and all of you joining us here this morning are aware of the impact of stroke on individuals. It is the third leading cause of death and disability, and 7,500 people have a stroke in Ireland every year. And thousands of individuals are living with disability and residual disability as a result of their stroke. And many of them describe to us as healthcare professionals and to advocacy organisations, and in our conversations with them, experiences of fragmentation of care and sometimes some lack of coordination in the fundamental components of stroke care along the stroke care pathway. And we can see that that stroke care pathway starts from the very early stages of the identification and the diagnosis of the stroke, the very early acute medical management in relation to those who are selected for thrombolysis and thrombectomy, their management in the acute stroke unit, progressing to the early stages of their multidisciplinary stroke rehabilitation, their transitions through rehabilitation to the point of discharge, and that transition home to other opportunities for rehabilitation, often including ESD or early supported discharge, and then life after stroke, which needs to include living well and healthy after stroke and linking in with community-based care. So we are aware that in Ireland there have been some improvements in stroke care, with many patients now receiving thrombolysis and spending time in stroke units, and advances and expansion of early supported discharge services. But we also know that numbers of stroke patients are going to continue to increase both in Ireland and in Europe. Next slide, please. We also know that research funding can sometimes lag behind in stroke, so we are very fortunate and very excited and very grateful to the Health Research Board for funding iPASTAR and providing us and our scholars and our consortium members the opportunity to advance the evidence base in stroke care, which will impact on stroke services and policy at the end of our programme. Next slide, please. Public and patient involvement, or PPI, is embedded at all stages of iPASTAR, our Collaborative Doctoral Award. When we were preparing our application for funding, we met with over 20 stroke survivors and stroke group coordinators to listen to their stories of their experiences of stroke and their experiences of stroke services. And many of them described to us in that focus group how they often experienced falling off a cliff when they were discharged after stroke, maybe a lack of a coherent plan in their case, challenges after acute stroke management and thrombectomy, and what the next stage of their recovery was going to include, and living well after stroke and how they could manage the after effects of their stroke and lead healthier lifestyles in the future. So we listened to our public and patient partners at the very beginning, at the very outset, and that informed how we shaped iPASTAR and the projects that we were going to focus on. And indeed, PPI, as you will hear later on in our symposium this morning, is embedded in all of the iPASTAR projects, in all of our activities, the project design, the project methods, and conversations with the PhD scholars, and indeed embedded in our governance and management to progress all the activities that we've incorporated in iPASTAR. Next slide, please. So what are we going to do in iPASTAR? iPASTAR is very much about capacity building, and iPASTAR will generate a cohort of research who will be leaders, who will carry on stroke research into the future and continue this work. And they will have transferable skills to make a future impact and to drive the evidence base to have an impact on stroke care and policy in the future. And we've identified 4 key areas that we're focusing on in iPASTAR. And this will be focusing on the acute care pathway in terms of barriers and facilitators at this stage of the care, the transitions of care, and linking in with early supported discharge, living well and having healthy lifestyles and maintaining wellness after stroke. And culminating in these changes will be the cost of these changes. So a health economics component to look at programme budgets going forward for stroke care pathways. Next slide, please. So within iPASTAR, we have 4 PhD projects, and you will hear more about these projects later on in the symposium this morning from our 4 iPASTAR PhD scholars. Our first project is looking at accessibility and equity of acute stroke care, and that is led by Dr. Deirdre McCartan, who is a physician. Our second project is led by Geraldine O'Callaghan, a physiotherapist, and Geraldine will be looking at improving and supporting transitions of care after stroke. Project 3 is led by Patricia Hall, a nurse, who will be looking at staying well and reducing risk after stroke. And Project 4 is led by Claire Fitzgerald, a health economist, who will be looking at the costing around stroke care pathways. So we are very fortunate to have a multidisciplinary team of researchers and within our consortium leading iPASTAR. And this is supported by a training programme, mentoring and career development for our scholars, and a very robust programme governance and management structure with PPI, public and patient involvement, embedded along all stages of the iPASTAR work. And this will culminate in us generating evidence to inform stroke policy and practice going forward. Next slide, please. Our iPASTAR consortium includes a range of experts and in academia, in stroke clinical care and practice, leaders in stroke care who have a range of experience in methodologies, who have been advocates for improving stroke care in Ireland and both internationally. And our international and national partners are supporting us in both our steering groups and international advisory groups to guide us as the investigator team leading iPASTAR over the next 4 years. Next slide, please. Within iPASTAR, we have a very specific training programme to support our PhD scholars. So our scholars have completed their 1 year of training as part of the SPHERE programme, the Structured Population Health Services Research Programme. They will go on to complete bespoke iPASTAR training workshops as part of our programme of research. They have completed in year one their national placements and will go on to complete international placements in centres of excellence. And again, this is very much sharing and collaboration and learning from other experts and broadening our network of stroke researchers so we can make an impact in stroke policy and practice. And this will culminate in enhanced leadership capacity, which is the fundamental principle of the Collaborative Doctoral Award funded by the Health Research Board of Ireland. Next slide, please. So our key messages are that, iPASTAR is focusing on stroke. It is patient-focused. We have generated clinically relevant, clinically important questions by listening attentively to our PPI partners and our own experiences and reflecting on challenges that have been documented, advances in stroke care policy, both nationally, internationally, and in Europe, and looking at that stroke care pathway. We have a very strong leadership team to support the scholars and to support all the activities of iPASTAR going forward. And this will be enhanced by career development. So we look forward to sharing with you all at future events our progress and sharing the findings of our studies as we progress over the coming years. Thank you. So I'm delighted to now welcome Professor Bo Norving, our keynote speaker today. Bo is Senior Professor in Neurology at Lund University, Sweden. He has a long and fruitful research career in clinical stroke spanning over more than 4 decades. He was corresponding author of the Swedish aspirin low-dose trial, published in The Lancet in 1991 as the first trial to demonstrate the benefit of low-dose aspirin therapy for the prevention of stroke. Bo has served as editor for the European Stroke Journal, and he is a founder of RIX Stroke, the world's first national stroke registry. He was president of the World Stroke Organization from 2008 to 2012, and he has been the stroke representative at the World Health Organization and the United Nations for many years. He chaired the steering group committee that developed the European Stroke Organization ESO Stroke Action Plan for Europe 2018 to 2030. And we are delighted to have him as our invited speaker today to talk about this important topic. Thank you very much, both.
Thank you very much, and thank you so much for inviting me to this project and for this webinar today. I must say I'm delighted, I'm overwhelmed, and I'm so pleased to see this activity that is coming up now. I'm sure it will have a very, very huge effect on the stroke care in Ireland. It's a wonderful investment, and I think it's just a brilliant idea. So I'm happy to speak to you about the Stroke Action Plan for Europe, and I will update you on where are we now in these initiatives. So the next slide, please. These are my disclosures, nothing relevant for this presentation. And the next one, we could go back if we are looking at big actions in Europe to improve the stroke services back to 1995, where it was the first Helsingborg Declaration on stroke management in Europe. The initiative was taken by Kjell Asplund, who was at that time the chairperson of the European Stroke Council, and it was in collaboration with WHO, the Regional Office for Europe, and the European Stroke Council. So there were several other organizations that also participated in this work, but really this was an historical declaration. It was the first time that Europe came together, and it was also in cooperation with WHO Europe. So the next slide. The format of the Helsingborg Declaration, it was a physical meeting with a few hundred persons attending, and it's established the essential principle for good practice. It was setting targets for 10 years ahead, and it was identifying research priorities for 5 domains. And you can read it was the organization of stroke services, the management of acute stroke, secondary prevention, rehabilitation after stroke, and interestingly and importantly, also evaluation of stroke outcome and quality assessment that was emphasized already at this time. So 25 years ago with stroke, these are historical times. It has changed so much since this period. So next slide. So what happens was that about 10 years, actually 11 years after the first Helsingborg Declaration, it was organized a second Helsingborg Declaration with very much of the same format. I can take the next slide. And again, it was a similar format that was used here with a review of what is the evidence base now, what are the targets that should be set 10 years ahead, and research priorities. It was very similar to the first one, but it was really rewarding to see that very much of what was introduced as research priorities in 1995 had been to a large extent accomplished 10 years later, but they were far from fully implemented in clinical practice, really. So the next slide. So about 10 years later, the discussion came up again that do we need a new Helsingborg Declaration? We were looking back to these documents, and could it be said that these were effective documents, that this led to a major change, that the ideas, that the targets have been met? And the answer was very clearly no. It was still very much to be done in Europe. Very much of what was the intent of the Helsingborg Declaration has not been achieved. So the idea came up on a quite short notice to start up and establish a new Helsingborg Declaration, now from the European Stroke Organization, and the decision was taken in December 2016 to proceed, and this time in cooperation with the patient organization for Europe's SAFE. Everything was in a very, very short time period. It was very hectic. It was very intense. Next slide. So the work started, and I got the task, the quite heavy task, I must say, to lead this group of more than 80 persons from all around the European countries, and with committees and with subcommittees. It was one of the most difficult manuscripts to write and to finalize the text, because there were many areas where there were disagreement between experts. Should it be done this way? Should it be done this way? It needs diplomatics finally, and it came quite quickly that we nevertheless were able to finalize this and to present and publish the action plan for stroke in Europe 2018, and we set the timing up to the year 2030. So next slide. So now it was called the European Stroke Action Plan, and this time it was 7 domains of the action plan. You remember from the Helsingborg declarations that there were 5 areas at that time. Now was added a separate domain on primary prevention. We thought that had been neglected. This is crucially important. And also added another domain, life after stroke. And this was added actually from the initiative from the patient organization. Initially, they wanted for each of the domains to have a separate final section of what does it mean to life after stroke. And after some discussions, the idea came up that no, this is so important, this is a domain of its own, it should be a separate entity, a separate domain, and we are very happy for that, and we can thank the SAFE for taking this initiative and coming up with this proposal. All of this work is totally free from involvement from industry. And we have been extremely careful for this, that there should be no pressure, there should be no industry interest in this. This is simply from an evidence base and to setting the targets, and with a very clear independence from industry. There was also a separate group, as you can see, on prioritized research in translational stroke research. So the next slide now, we follow the same format again with a little change. We had the first state of the art, and then we had a section on state of the current services in this domain. We looked into research and development priorities, and again, we set targets for the year 2030. So some modifications of the original Helsingborg declarations, but a similar format that we have found to work quite well. So next slide now. So there were 4 overarching targets for 2030. For each of the 7 domains, there were a lot of different targets, very specified targets, but there were 4 targets that we felt that these are overarching. These are the main things that should be achieved in 2030. And the first one, it was to reduce the number of strokes in Europe by 10%. Why 10%? We did a lot of calculations on this, and the background is that there will be a change in the population in Europe, there will be a change in the demographics, in the increasing proportion of elderly in the population, and we need to counterbalance this by reducing the risk of stroke. And even more so that we not should only counterbalance it to have a break even, but we should actually reduce it. So you may think that to reduce the number of strokes in Europe by 10% is very tough. You have to counterbalance the aging of the population, the increasing of the population, and still you have to get the absolute numbers down. And you have to look at the absolute numbers for the hospital services to survive. They cannot take on so many more stroke patients. We need to prevent, we need to reduce the number of strokes to be effective. And the second overarching target was to treat 90% or more in a dedicated stroke unit as the first level of care. Very, very important target, basic really for stroke care. Third one, to have national plans for stroke. Another very important target. I will come back and speak separately on this. And the fourth one, not only for stroke, but national strategies also for multi-sector public health interventions. And this aims to primary prevention, to have healthy lifestyles, to do things in the population that can help to prevent strokes, and also to improve the situation on life after stroke in a much broader perspective. So these are the 4 overarching targets which are very important. Next slide. And this is life after stroke. And again, we are so happy that this was a separate domain, because more and more we recognize that this is so important. It's not only the very medical limited aspects of stroke, it also the effects of patients and the family is very much of humanistic aspects on how the community is treating patients with stroke, taking care for patients with stroke in all the different needs and aspects that they want really. So very much to do here. It's been very, very much neglected. Next slide. So can we hope this time now that the action plan should have any effect on the situation in stroke? And as I said, if we look back on what was achieved actually by the first Helsingborg Declaration, I think we can say frankly that they were not fully effective. There was not an implementation plan. There was not a strong group that pursued the implementation of the Helsingborg Declaration. It was a reference document for governments and for different groups that they can refer to. This is recommended, but there was really not any clear, very strong implementation plan. Is it better now? Yes, I think we have a better knowledge on how to make implementation of mechanism and the coordination. We have a very much stronger scientific society in the European Stroke Organization. We have a much better leadership. We have all relevant stakeholders on board this time, and very strong also from the patient involvement. We have a much stronger case, knowing much more about the benefits of investing in stroke prevention and stroke care. We have a demonstrated proof of principle that investments will make a change. It can work. We have better data, we have better systems to monitor the progress, and we have now a long-term plan. So I think this time I am hopeful, really, but it's really a challenge to implement this, but I'm hopeful this time that we are much more stronger. It's a much better situation. Next slide. So implementation of the national or the action plan, this has now started. It was a launch at the ESOC in May 2019, a launch at the EU about 1 year later, and now this is rolling out, and I will give you some of the details on this implementation plan, which is now very strong, and I'm convinced that this is one of the most effective way to make a change in the stroke services is to have a work like this plan that is in the European Stroke Action Plan. Next slide. So there is an implementation committee, and you can see that myself and Valeria Kasi was my co-chair in the preparation of the declaration. And after we had done that work, we felt that now it's time for us to step down. We need the younger generation. We need other people to come up here and form the implementation committee, which is now working very hard with the implementation work. So the next slide. So this is now it's changed the term to Stroke Action Plan for Europe, the SAP-E. This was a background that there were trademarks that were already taken, and this one was free and open. So we're speaking about the SAP-E now for the Stroke Action Plan for Europe. Next slide. So it's very important here to have national stroke plans. And you saw that that was one of the overarching targets. So it really doesn't help to have only a regional stroke plan for Europe. You need to come down to the national level, because it's a case for the health systems that every country is autonomous in healthcare decisions. Sweden makes their own decisions. Ireland make their own decisions on the organization of the health services within its own country. So you need to come down to the country level. There are wide variation in resources, traditions, health system priorities between different countries. So this is why we're so much focused now on not only to have the regional plan for Europe, but to reach on the national level and work on the national level. And this is also for resources, that this is on the national level. Next slide, please. So one of the first countries to take up a national stroke registry was the UK, and we know it has a very profound effect on the stroke services in the UK. Next slide. So what we want here really is, you see what I highlighted up on the top of this slide. Stroke should be a new national priority. This is what we want. This is what we are looking for with a national stroke plan. Stroke, a new national priority. So the next slide. We need to have very good arguments when we are speaking to the health professional, when we are speaking to administrators, when we are speaking to politicians in our own country. We need to have very strong arguments, because it's a competition with other areas, with other diseases. It's a very strong competition, and we need to have very solid, very sound arguments that why should you focus on stroke? Why should you invest in stroke? Why should you do this? And the reason behind is that stroke has been behind. Stroke has been in the shadow. It's been too little for stroke. It's time now that there is more visibility and actions on stroke. And we can also say that if you do this, we know the evidence base. We know that it will work. We know that this is a good investment. It will bear fruit. So we have very, very strong arguments. So you can see some of the arguments here listed, that we can say that this is the size of the problem, and it's an experience that this is not enough just to say that there are so many cases of stroke, because every disease comes up and say we have 10,000 of us, we have 20,000 of this disorder, we have 5,000. It's very difficult. You cannot argue with the number, really. You need to go back to an evidence-based source document and action plan and say that we have an evidence base for what we do. This is proven, is a good support. We have evidence support of our actions. We need to demonstrate that there are gaps, there are inequalities in the occurrence of stroke and in stroke services. We need to show that substantial improvements can be made and demonstrate that actions are extremely cost effective for the society, and we need to measure progress and see the development. And I would say that in my view there is no other disease that has this advantage situation that stroke has today, that we have all of these strong arguments at hand. My say is that there is no other disease that can beat it, and of course there are other that can compete, but it's a very strong case for stroke now that we have with the development that has taken place, really, that there are few other diseases that really can have as strong arguments as we have for stroke now. So we should use that really, and we should use it smartly. Next slide. So the vision of the implementation place is now going to the national countries, be country specific, countries are different, provide a framework for quality improvement in the individual countries, focus on the most important elements, provide a platform for benchmarking of key figures, and engage authorities, healthcare providers, patients and carers in reaching out our common targets. So next slide. This is from the website of the European Stroke Organization, and you can read that one of the largest stroke initiatives that has ever been undertaken. And I think you can read that once more. One of the largest stroke initiatives that has ever been undertaken, really, is a very, very strong initiative for stroke. And this is very much in our hands, what we will do out of this. Next slide. So what is the situation? Well, this is a survey that was done a few years ago from the European Stroke Organization, and it was a survey in 44 of the European countries. Next slide. And what was shown was there were huge inequalities between the different countries. And if we look overall, we can say that about half of the basic core items for stroke care was implemented in the European countries. Half of the patients got access to reasonable, decent care. Half of the patients in Europe did not. So it's really, really not a very good situation. It's really huge gaps. It needs to be improvements. So next slide. So what has been defined now in the Stroke Action Plan is monitoring of 12 key performance indicators, and I will not read them to you, but I think those who are knowledgeable in the stroke field can see that these are the core elements of what you should do in stroke practice. So the next slide. Here you have the 12 just for reference, and I will not read them to you. They are widely available to be read. Next slide. So what will be started now early next year is there will be a collection of data from all of the European countries. They will open a website where we can monitor or we can display what is the progress, what is happening in the different countries in Europe. There will be a collection of data for every year, aggregated data from each country. So this will very soon be in place, and this will have a very important function. And it's been called the SAP-E service tracker, that we can track the development of the services. Next slide. So I will show you a few recent graphs that we are taken up in the Swedish Stroke Register to demonstrate the inequalities in Swedish stroke care. What we have in this slide are 8 of 1, 2, 3, 4, 6. No, it's actually more than 8. We have the core elements of quality of care that we measure in the Swedish Stroke Registry, and you can see this illustrated each of one, and you can see the different in the different hospitals in Sweden. And those dots which are marked green means that the hospital performs okay. It meets a high level of performance. If there is a yellow dot, then it means that okay, it's sufficient, but it can be improved. And if you have a gray or black dot, it means that you are below the target. You don't come up to good services. So here you can see of some of the different items. You can look to the left and see the situation for reperfusion. You see a number of green dots, but you see that there are more yellow dots and there are very many gray or black dots. Here it is a widespread over the country. The targets have not been reached. Is a huge variation. If we look at the next line, the door-to-needle, go back to the next line, the door-to-needle proportion treated with 30 minutes, you can see that there is a huge variety across the country. You can see that it's almost entire spectrum here, that there are some very good performers and there are some very bad performers. You can move on to go to recording of NIA stroke scale. Very, very much difference in the country. And as a contrast, you can look about on the use of antiplatelets after ischemic stroke. And here you can see that almost all hospitals are green. This is working well. So we have started to use this now to illustrate the overall pattern of what does it look across the country. And I think this is a very nice way to illustrate it, that you can very rapidly get a grasp on, are there huge differences, are there inequalities, which are the key areas which are problematic. Next slide now. So we can follow this over the years. We can see the improvement in the anticoagulation therapy after ischemic stroke, in atrial fibrillation, but you can see it is a quite slow progress. Next slide. This is a proportion of ischemic stroke treated with reperfusion. And this is very important, with thrombolytic therapy and thrombectomy. And you can see that despite the huge efforts that are being made, it's very, very slow progress in this field. It's no easy way to change practice. Next slide. Is proportion of thrombolyzed patients it should be under 30 minutes, the door-to-needle time. And what you can see here is not very much of improvement, really, because despite this is so important, this is what the hospitals can do in their own, but it's very difficult to achieve. So next slide. So it's a lot of different things that is going on in the SAPI implementation plan. It's a service tracker, it's a lot of activities on the national level. It's very, very active program. It is now ongoing, and you can go to the SAPI website and see all the references and the documents on what is ongoing. Next slide. Very much focus on the national coordinators, and I think in the sake of time that we can move on to the next slide. You see Ireland also have a national coordinator in this work, and next slide. You see that the people from Ireland are active here. Ireland is not located in the center of Europe, it's rather in the periphery, but I'm very, very pleased to see the activities that is coming out from Ireland. It's wonderful activities, really, that is improving very much. It's very active, and what you are having today is part of this, of course, with this research activity that you should be very proud of what you are doing in Ireland. You are really very much, we have the eyes on you, that you are doing extremely well, and you are very, very active. Next slide. SAPI declaration. We want the implementation to reach the highest level of ministries of health and politicians. So this is the need for the declaration, that we want each country to have a clear statement that there is a national plan for stroke and there is support for the development of stroke with a SAPI declaration in each country. This has been signed now by 3 countries so far, and we want more countries, of course, to sign this declaration. Next slide. There is also another important stroke action plan going on in Latin America. This is Sheila Martin, the upcoming president of the World Stroke Organization, is very much focused on implementation of stroke units in the Latin American program, but this has really started off very, very well. Next slide. So this is very important with the cooperation, and as I see it, is not only the European Stroke Action Plan by itself. I see this as a global movement now, that there are regional action plans coming up in Latin America and other parts of the world. This will go down to the national level, and in my view, I think this is the most effective way to implement improvement in stroke service overall, is to have this format as we have in the stroke action plan. I bring this up when there are WHO meetings that say that we have a very effective model for improvements. You can follow this model in other areas as well. We are strong in the stroke field. So next slide. These are my take-home messages. CEPI is one of the largest actions for stroke ever launched. Massive efforts are needed to make changes in clinical practice. It's no easy thing. It's a huge challenge really to make a change. The national stroke plans are key elements in the CEPI. A coordinated regional health plan with targets and national outreach like the CEPI is likely one of the most effective ways to improve health services overall. Stroke is a prototype area in the NCD field to demonstrate proof of principle of evidence-based medicine put into practice. The future for stroke is in our hands. We need leaders. You have leaders in Ireland, you have important leaders in research and in the hospital sectors and in advocacy, and we need really the strong leaders to make the improvements. It's very much in our own hands also what we do in this. And we are fortunate in the stroke field that we have all the good arguments at hand. Now it's very, very much up to us on what we make from this. So next slide. With that, thank you very much for your attention. I'm happy to take some questions on this and have a discussion. Thank you very much.
Thank you very much, Bo, for that wonderful presentation on the Stroke Action Plan for Europe, which has given us a great overview, I think, of all of the really important and different aspects to that plan. We have a number of questions in the chat, so I might just put those to you now, if that's okay. And a number of them relate to implementation. So one question is, what do you feel are the greatest barriers to implementation of good stroke care, and how might they be overcome?
I think there are 2 main barriers, and the first one is that there is a reluctance to make a change among the health professionals. That we tend to do like we have done in the past is very, very different to change practice. And we see that, for instance, with improvement in the door-to-needle times. We cannot blame them to anyone else. This is just that we need to be better, we need to be smarter, we need to do this more rapidly. But despite this knowledge, it's very, very slow in improvement. There is an inertia in making changes among the health professional, the way we used to work to make a change. And the other and more difficult barrier is that for some of these things, we also need structural changes. There is a lack of hospital beds. There is a lack of skilled professionals. We need better investments. And this is where we have the administrators and politicians to come up really to change anything there. And we know that this battle is so difficult to make an improvement in the hospital, to get more investments, to change at your local hospital is very, very difficult. But we need to fight in that way. Some things are in the hands of ourselves that we can improve in terms of drug deliveries and what we can do professionally. For other items, we have the barrier that we need more resources. And as I said, I think we have extremely strong arguments now to come and say, you should invest. Yes, there is a cost to this, but it will pay back to the society. This is the most important thing you can do as a politician, is to serve your population, that it will have a good health and you will have good health services.
Yeah. So that was a linked question that I had actually, was just that for each, it's very important at a national level that people obviously, implement the stroke action plan, but it does require politicians and policymakers to get on board and to be willing to make investment. And you said that I think 3 countries have signed up so far. So how do we say, as the stroke community, put pressure on our policymakers and politicians to actually commit to providing the resources needed to implement this plan?
I think you need to, first of all, you need to have access and you need to get access. And that is not always easy. And then when the opportunity comes, you need to have all the arguments ready. You need to have all your papers, your documents, your arguments, because there isn't like a second shoot in the rifle. You have one shoot and you need to do that. And I remember around 15 years ago, 10 to 15 years ago, I was taking part of several meetings at the EU Commission and were asking for increased resources. And the EU Commissioner said, well, last week there were the people from Parkinson, the week before there were those from kidney diseases, the week before we have those with cancer. So what should we do for you with stroke? You need to be well prepared and say, yes, we know what to do. Yes, we have good evidence. It's cost effective. We will make a huge effort. You need to prevent stroke, otherwise your hospitals will be flooded with stroke patients. We cannot take that. This is a survival kit that we need to develop now and have at hand and really work. So it is very, very, very difficult task. And what is striking me now over many years is that it's a very slow process. It's nothing that comes rapidly. You really need to fight for it and to work for it. But the key here is to have leadership among the professionals. That you need to have leaders that stand up really and are strong and visible, and everything that is visible and good advocacy for stroke is of importance. So you need to be on all the levels. You need to work together with the patient organizations also, because their voice is so important here that they really can face the politicians and say, you are not doing good enough. You are not a good politician for us. You're not doing what you should do.
And actually, that was a related question, was what role do patients and family members play in shaping the implementation process of the action plan?
Yes.
And they are voters at the end of the day too.
It is. And it's a different thing that we can say from our speciality as professionals, that we want the priority on this. And then it's always a thing that you can say that you are speaking for your own sake, you are biased. But the patient can say, no, this doesn't work, it's not good services, it's not what it should be done for this disease. It has a very much higher impact, and we should have respect for that really, and work closely together really in these efforts.
And Bo, is there a role that the WHO are playing in implementing the action plan, or what is coming up from the WHO in the near future?
I think what is coming up next year is something that you should all be aware of, and that there will be a WHO declaration which has a name of epilepsy and neurological disorders. Epilepsy first, because it started with epilepsy that were able to get the attention of WHO, and then it was linked to neurological disorders. But now, as you know, stroke is part of the diseases of the brain. Stroke is part of the neurological disorders. Stroke alone constitutes about 43% of all the disability burden of neurological disorders. Stroke is the main disease here. And there is a very, very strong declaration now from WHO urging member states urging ministries of health really to put the focus and priority on neurological disorders, including stroke. So I think we should all be aware of this. This will be a golden opportunity for advocacy to say that there is a declaration now from WHO requesting you to take action on this, exactly like the climate declarations, and say that this is what you should do in your own country. You should follow this, you should set your own targets, but there is an overarching recommendation from WHO, which is very, very important.
Yes, and that sounds fantastic in terms of just putting pressure on again to sign up for the stroke action plan.
It is, yeah.
A question, so I think another question actually relates to our current situation. So in the light of our current pandemic, what is the best approach to maintain our focus on stroke care and life after stroke?
Oh yes, this has been an enormous challenge on the stroke care. And first of all, we had this data that we saw in many countries, and we also saw it in Sweden, that it seems that proportion of stroke patients, TIA patients, disappeared. They didn't come to hospital, there were low numbers. What we saw in Sweden actually was that part of this was an artifact, that the hospital system was so severely stressed, there were delays in registration. When we looked at it in the longer perspective, no, the most of the patients had come to hospital. They have been there, but there have been so long delays in the registration and administration that we thought that they have vanished really. But we are seeing that the acute facilities were reasonably well maintained. A problem was that there were some patients from sheltered living, from nursing homes, who were not transferred to hospital for reasons that we think are not correct in Sweden. But we're seeing more now of that there's been very, very bad services in terms of rehabilitation and follow-up. And these are the data now that we're starting to see from the Swedish stroke register, for instance, that is very much worse for rehabilitation. It's very much after the stroke, really. It worked reasonably well in the acute phase, but when it came to the longer life after stroke, I think we haven't seen the consequences really yet of how, I think they are much more serious than we have thought.
Yes, yeah, sadly I think that is true. Bo, thank you so much. Thank you so much for your presentation and for answering all of those questions. There are other questions still coming in, but in the interest of time, I think we might just draw to a close there. But thank you so much again. What I'm going to do now is move to session 2. So just to give a brief introduction, our next session will be an overview of the 4 iPASTAR projects. So our 4 PhD scholars will present, starting with Dr. Deirdre McCarthy, who's working on the first PhD project, and she'll tell you all about that, followed by Geraldine O'Callaghan, then by Patricia Hall, and finally by Claire Fitzgerald. So thank you, and there'll be a Q&A at the end of this session also. Thanks, Bo. Bye-bye.
Thank you, Anne, for the introduction of this session. I'm Olive Lennon from UCD, from the School of Public Health, Physiotherapy and Sports Science. I think Professor Norving really pointed out to us the need for leaders and champions in stroke going forwards. So it's a great pleasure to start and hear from our future leaders in stroke from the iPASTAR programme. So we could begin here, please, Patricia.
Hello, my name is Deirdre, and it's my great pleasure to present Project 1 of the iPASTAR programme to you today. The title of this project is Maximising Equity and Accessibility to Acute Stroke Care Pathways in Ireland. And what we're trying to do here is to gain a greater understanding of the organisation and processes that are involved in the delivery of very high quality acute stroke care, because the first 24 hours of a stroke are a critical period, as it's during this time that the proven treatments of thrombolysis and thrombectomy can be given to appropriate patients. So thrombolysis is where we can give a very strong clot-busting drug in through the vein, and thrombectomy is where an expert neuroradiologist can remove a clot from the brain. So through this project, we hope to improve access to these treatments. So time is brain and tissue is the issue. We often say this, but what we mean is that delays in getting treated can lead to longer term impacts for the person experiencing a stroke. So the quicker that somebody can be assessed and treated, the more likely that they will live well after stroke. And in Ireland in 2019, 9% of people who were recorded as having had a stroke in Ireland had a thrombectomy, and 10.6% of people had thrombolysis. Now, in an international context, these numbers rate very well. However, we do feel if we could streamline the organisation of our services and the decision making along the chain, we could potentially improve the rate of both thrombolysis and thrombectomy. So the chain of care is complex because there's multiple steps and there's multiple critical junctures at which decisions need to be made under time pressure. So we want to understand where within this chain might we be able to intervene in order to reduce delays and to assist decision making to get more people to the hospital faster. So for example, it might be from a patient perspective in terms of their stroke symptom awareness and do they know what to do. It could be assisting the ambulance crew in terms of their clinical assessment and decision making in order to pre-alert the hospital of their concerns that it might be a stroke. Also to make sure that we choose the most appropriate site for a patient to go based on their clinical presentation individually. And also, we also want to see how we could potentially make sure that there's consistent care across all hospital sites so that all sites are performing at high level consistently day, night and weekend. So this is going to be a mixed methods approach, and we've started with a systematic review to find, well, what evidence is there already of processes that might work in terms of improving access. Then study 2 has got 2 components. It's going to look at time metrics in terms of performance of hospitals across the country, and also interviews with people who are involved in either giving or receiving acute care, so patients and staff members, to get their perceptions and their experiences that we might be able to learn from. And then finally, we put all that together and try to come up with an intervention that might work in the Irish context in order to improve access and to improve rates of thrombolysis and thrombectomy. So thank you very much for being here today at our launch. And now I'll hand you over to Geraldine, who's going to try to take you through project 2.
My name is Geraldine O'Callaghan, and you're very welcome to my research, Beyond Early Supported Discharge, Improving and Supporting Transitions of Care for Stroke. Stroke is a significant cause of death and long-term disability worldwide. The overall burden of stroke is increasing across the globe. Despite improvements in acute stroke management resulting in some excellent outcomes, many stroke survivors continue to have significant needs long after the acute event. The transition from acute and structured inpatient rehabilitation to home is particularly challenging and is a time when stroke survivors are most at risk of adverse events. We know early supported discharge is associated with improved clinical and process outcomes, such as decreased length of stay and improved quality of life. However, not everyone is eligible for early supported discharge, and there are limited resources in Ireland to meet the needs of all those who are eligible. The literature tells us that stroke survivors discharged from acute, inpatient or early supported discharge feel abandoned at home. They don't have enough information on how to navigate the health system in order to access ongoing rehabilitation or other physical supports. They need information on living well after stroke, such as managing fatigue, physical activity, and psychological issues, and advice on returning to driving and work. A wraparound support intervention that would bridge the gap and meet the needs of stroke survivors is required. Our aim is to inform and drive improvements in transitions of care after stroke by understanding the long-term needs of stroke survivors and by identifying the effectiveness of and preferences for supports provided at transitions of care. A systematic review will answer what support interventions provided when people transition from hospital to home are effective in improving outcomes after stroke. What does the international evidence say? We don't fully understand the needs of Irish stroke survivors when they transition from either acute, rehabilitation or early supported discharge services to independent living, but we would like to. From our observational study, we will recruit stroke survivors from 2 Irish hospitals and identify their outcomes and needs at the transition from hospital to home and again at 3 and 6 months. Qualitative focus groups and interviews will ask, what are stroke survivors, carers and healthcare professionals' experiences, perceptions and preferences for supports provided at transitions from hospital to home. The systematic review findings and the findings from the needs assessment, strengthened by the qualitative piece, should all integrate together to feed into the design of a transition of care intervention. Thank you all so much for listening to me, and I'm going to hand you over now to Patricia, who will take you through Project 3 of the iPASTAR programme.
Hello everyone, I'm Patricia and I'm delighted to present my programme of research, which is the 3rd iPASTAR project. My background is cardiovascular nursing, and I've also worked with heart and stroke organisations supporting and educating patients and raising awareness of disease prevention and risk factor management. The focus of my research is stroke secondary prevention, as I believe recovery after stroke needs to encompass keeping survivors well and free from further events. As treatment and management has evolved, the perception of stroke is changing from being seen as an acute event to a chronic condition. And there's major risk of recurrent stroke, which is associated with worse prognosis. Lifestyle risk factors account for up to 90% of risk, and these are amenable to lifestyle change. But there's limited data on addressing health behaviours. Though recent reviews show benefit, there's no clear recommended strategy. This largely untapped area is the area of interest in my project. My research question asks, how can we best support individuals after stroke to stay well and reduce their cardiovascular risk? It's a mixed method study designed to bring together 3 studies to determine and deliver a person-centered intervention for stroke secondary prevention. So a 2-phased approach is adopted in study 1. First, to identify effective, theoretically informed behavioural and lifestyle-based interventions, and secondly, then drill down into the theories or behaviour change techniques underpinning effective interventions. In study 2, I will collect stroke survivors' experiences and perceptions of where and how lifestyle-related risk factors were addressed along their stroke care pathway. This will then help interpret and refine the programme theories under development in tandem with the data synthesis proposed in study 1. The integration of study 1 and 2 with our PPI and stakeholder collaborations will fully inform the co-design element of the intervention development. And finally then, a pilot feasibility study will be conducted to process evaluate the co-designed intervention in community settings. The MRC framework for developing and evaluating complex interventions will underpin the entire project. I'm currently completing the first phase of the systematic review, screening for inclusion of studies before extracting the data for synthesis. I have front-loaded my research capacity with formal training. We're working closely with our PPI champions and panel and stakeholders. I've received invaluable feedback and support of my thesis proposal, and am currently preparing for my stage transfer in UCD in January. I've also availed of the opportunities to learn and get involved with the wider research community and continue my outreach work with the Irish Heart Foundation and CRE. This study will inform and be informed by the other iPASTAR projects, and I look forward to reporting data from the different stages, which will be disseminated through our website, stakeholder engagement, national and international conferences, along with publications which will form the main body of my thesis. Thank you very much for your attention. I'll pass you on now to Claire, who will take you through the final project. Thank you all very much.
I'm going to give a brief summary of my project, the cost and cost effectiveness of current stroke care pathways and the developed interventions through the iPASTAR programme. First, a little bit of background. Economics is the science of scarcity, and when health economists say scarce, we mean that there is a limited budget given to be spent on health, and it is important that value for money is achieved when allocating where this budget is spent. To assess a healthcare program's value for money, we often conduct economic evaluations, which involves measuring the inputs, that's all the costs, and outcomes, the benefit to a population or group of patients. Within this evaluation, health economists ask if an intervention is equitable, that is, has it a fair distribution of resources, is it effective, does it work, and is it efficient in that it will maximize health. Some of the challenges that are encountered when measuring value for money within stroke care are as follows. Many stroke rehabilitation services and interventions are complex in that they involve a number of different components, which can make it difficult to understand the driver of better health outcomes and how much investment is needed to improve health. Preventative strategies and structured support programs offer much to a person's life after stroke, but the effects are often seen in the long term, and so new ways of calculating the potential cost saving are necessary to calculate the cost effectiveness. There are also hidden costs and costs that are not well understood or are difficult to measure, such as informal care and productivity loss. My PhD project will focus on exploring how good value for money can be achieved within Irish stroke care services while tackling these challenges in novel ways. I will develop a framework that can be used to assess the cost effectiveness or value for money of non-pharmacological stroke interventions. The framework will be a Markov model calibrated with the best available data on the effectiveness of stroke interventions, outcomes, and costs. I will also develop a method for obtaining long-term healthcare costs and labour-marked consequences for people who have been discharged from the hospital-based stroke services. In my preliminary review of economic modelling, I've identified less than 10 economic frameworks that are assessing value for money of stroke services. However, no general framework has been developed with an Irish perspective and calibrated with Irish data. This would imply that there exists little research-based analysis that can guide decision makers to where additional investment and new development may improve value for money and thus support patients with stroke to regain their previous health and quality of life. It is my hope that my work will offer new economic insights into difficult decisions about how stroke services should be organised in the future. To achieve this, I have designed 4 studies which will work to fill the gaps in knowledge and data and help advance evidence-based and cost-effectiveness stroke care pathways in Ireland. Thank you for listening, and I look forward to any questions you might have.
Well, thank you to all 4 scholars there. I think we can see that they have capacity here to make really meaningful impact across stroke care settings and wider into the community. Next up, we have a session on PPI experience. As Francis mentioned, in iPASTAR, we're committed to embedding PPI across all stages of the research process through developing the questions, through grant writing, onward through protocol development, through the research activities, through interpretation of our findings, and onwards in the future to disseminating these findings to all interested parties and audiences. So we're going to have a recording of a conversation between myself and Mary Scullion. Mary is a partner with us on the PPI team. Thank you. Okay, hello everybody. My name is Olive Lennon. I'm a partner on the iPASTAR Collaborative Doctoral Award. I'm delighted to be joined here today by Mary Scullion, who is our patient and public involvement representative and who joins us as a partner on iPASTAR. Thank you for joining us, Mary.
No problem, Olive.
Mary, can I start by asking you, how did you come to be involved in the iPASTAR Collaborative Doctoral Award as a patient and public involvement representative?
Yes, Olive. Well, really, I suppose I'll start. I'm a speech and language therapist by profession, and prior to my stroke, I was working as a speech and language therapy manager part-time in a child and adolescent service, and I was job sharing that role with my job share partner. I had my stroke about 4 years ago at the end of 2017 on a Saturday afternoon, the day before New Year's Eve, and it was caused by a carotid artery dissection and it affected the left-hand side of my brain, so the right-hand side of my body was affected. I also had aphasia as well, and I think that was predominantly to do with higher level language and word finding, and I had dysarthria as well. I was right-handed, or am right-handed, so anything to do with using my right hand was compromised, including writing, and obviously my walking as well. My leg was affected. I ended up in the local A&E unit where various tests and scans were carried out. And then on the Sunday morning, the day after my stroke, I was sent by ambulance to Beaumont for a thrombectomy. And after that, I was transferred back to my local hospital. I think I spent a bit more time in A&E and ended up as an inpatient in the neurology ward. During my time there, I availed of all the therapies. I had assessments with the physio, the speech and language therapist, and the occupational therapist. I then started therapy with all these disciplines, and on day one of speech and language therapy, I could not name pictures of a banana or a hat. And it was certainly a different kettle of fish being on the other side of the table. And at that stage, I was also using a wheelchair. About a month later, I got transferred to a different hospital which had a stroke rehab unit in it. And there I received more or less a daily physio, speech and language therapy and occupational therapy. I stayed there for approximately 3 months, and towards the end of my time there, I was referred for outpatient follow-up in a local rehabilitation hospital. I was discharged home from the stroke unit in the mid-May, and at that stage I was walking with a stick. I continued to do my physio and speech and language therapy work by myself at home while waiting for outpatient follow-up. I remember being annoyed that I had my stroke under 65, as those in the unit over 65 were being discharged, were offered 1 day a week outpatient services at the day hospital in the stroke unit. I think I was called for outpatient physio late summer and attended maybe fortnightly initially, and then later more infrequently. I also attended outpatient speech and language therapy, and we agreed that at that stage I didn't need further speech and language therapy intervention. I attended outpatient occupational therapy to do with driving and returning to work. I suppose at this stage I feel very lucky to be alive, and I'm extremely grateful for all the therapies I received, and feel the reason I think I am so well now is because of my thrombectomy and all of these therapies. As a speech and language therapist, I have been involved in research and writing papers and position papers in my own field. I know about devising my questions, seeking ethics approval, recruiting my participants, reviewing the literature, and writing up my findings. So you can see I've experienced many of the different pathways after stroke and rehabilitation. During my time at home, I got invited to a forum in RCSI with fellow stroke survivors. We all got to say about our experiences and where we felt the shortcomings were. For me, the biggest gap was being discharged home from the stroke unit with no outpatient physio in place and having to wait for that to come up. Out of the forum, a few different strands of gaps came up, and these were later transformed into questions by the iPASTAR scholars to investigate in their PhDs. I was impressed with how the issues discussed at the forum were translated into meaningful research questions. I am also delighted that I was invited to be the patient representative on the iPASTAR steering committee, and have attended these meetings, and I've also attended meetings facilitated by the scholars. It is so great to see the, oh no, that's it.
Okay. Yeah, I remember that forum very well, Mary, and indeed we're very grateful to all of the participants who came that day and for the meaningful discussions that we had that helped us in guiding this. Can I ask you one more question before we leave today? What do you hope iPASTAR research will achieve?
Oh, yes, it's so great to see the work that scholars are involved in that will hopefully make the path for stroke sufferers easier and more seamless and more fruitful. I am passionate about improving services in both my own field of work and in the field of stroke. I know we can't prevent all strokes from happening, but we can improve the pathways and outcomes, hopefully, for those who have suffered a stroke by working together. And really what I hope for with the iPASTAR is that the research conducted is translated into improved care for stroke sufferers. I hope that they can move seamlessly through different strands of care and not have to wait for the next bit. It's a continuity of care in a holistic way. I hope that their well-being in every sense of the word is improved, and I hope that there are no gaps between services. I hope that the availability of services will increase and meet the needs of people post-stroke. I feel all the research projects are very exciting and take a different angle of life after stroke. I feel they will add weight to the body of research on surviving stroke, and I'm delighted to be involved in a small way.
Oh, thank you very much, Mary. I think we're very lucky to have you. Your dual skills as a therapist and somebody who has experienced stroke. Indeed, we're very lucky to have you in iPASTAR. Thank you.
Thank you, Olive.
Okay, so we're going to open up the session now for a panel discussion. We'll be joined here on the panel by the iPASTAR scholars and by Mary Scullion, our PPI representative. If I might open the discussion myself first to ask the scholars, we know that in a collaborative doctoral award, it's greater than the sum of its individual parts. So I'm curious how you guys collaborate together to work on higher level outputs for your project.
Hi there, I might take that. So what's really special about this collaborative group is that we all come from different backgrounds. I myself am doing the health economics. Deirdre is from a clinical background, she's a medical doctor. We have Geraldine, who's a physiotherapist, and then we have Patricia, who's from a nurse clinical background. So that means that we all have our own expertise and specialities that we bring, and we all bring our own strengths when it comes to collaborating with our different projects, and all bring different insights. We meet about every bi-weekly, and then we also have meetings with our PPI panelists 6 to 8 weeks. And this has been a real cohesive project for us, building PPI and collaborating with them. And through our PPI, we've learned our own strengths because they've been brought out, but also we've learned a huge amount from our PPI partners. And I think that might lead on to Maggie's question on.
Okay, we have a great question in here from Professor Lawrence from Glasgow Caledonian University. She said it's heartwarming to see the PPI element is so strong in this programme of work. And she'd like to ask you how you think your projects individually and across the board will benefit from this, and how do you plan to measure the impact of PPI in the projects?
I might take that, Dr. Lennon. So PPI it's really been essential to what we've done. We didn't really know that when we set out. We've had just about over a year now of working with our PPI partners, who I'd like to welcome because I can see them in the chat there. Kleena is here, Julianne and Philip, and I think Martin has also logged in, and of course Mary is here. So there's 3 parts to that question. Thank you, Professor Lawrence. So I suppose at an individual level, or from our 4 projects from that level, we've already had huge insights into the areas that are very important for people who are living with stroke and people who have experienced the pathways, whether that's acute and the inpatient aspect, the rehabilitation and the discharge home, and also those cost components. So for example, if I give you a couple of examples of our sessions that we've had, Claire, for example, had a recent session with her economic questions, and we were trying to talk about costs. And one of the key areas of her project, in fact, it changed based on our PPI session, was looking at hidden costs. So we were trying to flesh out, well, what are some of the hidden costs that maybe aren't being accounted for, whether that's, for example, GP costs after discharge, the importance of psychological support, which really isn't available. We've noted that already, and the costs of that as somebody tries to get back to life and back to work. And then that work component being so important because there's a huge loss of income from from that acute phase, but also from disability later for a lot of people. And we know that there's a huge proportion of young people of working age who need to get back to work. So talking about that, Claire is actually able to redirect her project. Another example would be very recently, just last week actually, Geraldine is putting in some of her ethics applications, and she was able to ask our PPI partners, we call them our champions as well, and we have a few different terms, but they certainly are champions, to give their insights into the patient information leaflet, which would be presented to the patients who we were hoping to recruit for her second stage project. And our partners were able to give us such an incredible insights. It wasn't about font or font size. It was, well, really there should be a voice, a voice that we can hear for people who experience aphasia, for example. So she was therefore able to make a video on YouTube. And then another, Julianne said, well, why not have a QR code? So now Geraldine has a QR code on her patient information leaflet. So they will be able to link directly to her YouTube voice description of the patient information leaflet. So it's been huge. And then in more generally, like referring back even to Prof. Norvin, who mentioned about advocacy. So our PPI partners are going to be very important in that later stage, trying to disseminate our research, because we will work with them and with other patient advocacy groups like the Irish Heart Foundation in order to get the results out, because we want good implementation to make sure our projects are effective. And the last part of that question was about how are we going to measure it. So I suppose measuring PPI is in a quantitative way is kind of difficult, but we are certainly going to have narrative components describing the importance of them within all of our projects. And likely there will probably be another project later on which will actually look at kind of trying in a way to look at that from a qualitative perspective, to try to get a real sense of what the impact was of the 4 projects, but that's probably going to be a separate project. So that's it. Thanks.
Thank you, Deirdre. A number of people have posted in thanking Mary for highlighting the frustrating age restriction and access to rehab post-stroke for those under 65. So thank you very much for that, Mary. We have another query in here wondering what kind of barriers are you guys experiencing in embedding PPI in their projects? And you've given us how you're doing it, but there's some questions about barriers.
I'll take that, Olive. Thank you. Thanks, Geraldine here. I think that we might have expected more barriers, and in particular, the lack of face-to-face could be seen as a barrier, not being able to sit together and sit down together in the one room and engage in the PPI work. But I think both COVID has made everyone more digitally literate, and it's become, part of our world now. So it's not so much a barrier as it would have been a couple of years ago. I think the fact that PPI has been involved from the very early onset in thinking about this project has made PPI naturally part of our work. So I think, that's not a barrier like we might expect if we were just trying to recruit PPI at this stage, and try and develop those relationships. The relationships were already there. So I would say less barriers than we might have thought. All our PPI contributors have been so approachable and generous with their time from the onset, keen to get going from the onset. Really, we're not working fast enough for our contributors, really, which is amazing. And I think being so generous with the skills they have themselves outside of their actual experiences of stroke, which has been amazing for us. And I think maybe I've covered most of the points I wanted to cover there. Anybody else wants to jump in, but I think not as many barriers as we might have perceived initially.
Thank you, Geraldine. And just one final question. There's been great audience participation here in the chat, but this is our final question on this session. So anything unanswered, please email us directly to the iPASTAR email address that'll be coming up next if we haven't got to your query. But one last question in here. How would you recommend that people include PPI in their local quality improvement projects in acute stroke units?
I might jump in there, Justin, just to say that really it's about being open and inclusive. you know, inviting people. Everybody wants to have a voice, and our champions are real champions, and they've been there with us through, you know, from the very start. So people are just delighted to contribute. They want to give something back, I think. So be open and inclusive to it. I think that's the bottom line. And yeah, just go for it, because as Thilo would often say, that's who we've learned a lot of PPI from, is, you know, it's not rocket science. So just no tokenistic stuff here. Just be open and honest.
Great advice, I think, going forwards. Well, thank you all to the panel and the participants who posted their questions. I'm going to hand back now to Professor David Williams for closing of the session this morning. Thanks, everybody.
Thank you very much, Olive. And just to remind people, you can follow all of our research and updates on the new website, iPASTAR.eu, which we're launching today. So it's a lot of useful information and resources, and a way of interacting with our research team. We would encourage this. And you can also email us at ipastar@rcsi.ie. Next slide, please. You can also follow us on our Twitter feed at hashtag at ipastar.stroke research. And final slide. Again, I'd just like to thank particularly our speakers, our scholars, and most importantly, our patients and patient advocates. We believe iPASTAR will act as an important voice for patients and families recovering from stroke. Most important person to thank today is Anne Moore, our administrator, who's behind all of this work. You can't see her today, but we can see the fruits of her labours over the last number of weeks in preparing this symposium. And we'd like to thank Anne particularly for her help today with organising the symposium. Stroke has been unresourced over the last number of years, and we are in competition. We hope that iPASTAR will help make us competitive, and importantly, advocating for our patients recovering from stroke. I'd like to thank everyone again for their time. I hope you enjoyed the symposium. We're looking forward to future collaboration with all of you, and finally to wish you all a peaceful and restful Christmas over the next week. Thank you.